what I want to do is talk about how you can prepare your registrar for the exam in a practical way. So most importantly, you need to know what's being assessed. The RACGP curriculum is massive, but there's a really much more simple document that I'd encourage you to have a look at and obviously have a sense of the domains. I want you to continue what you're doing and doing really well, and that's your practice-based teaching. Directing your registrar to appropriate resources is going to be part of that. At this point, understand what's being assessed. And so this document that I'm referring to is the RACGP Core Skills Unit document. Again, you can Google that. It's got there's a reference there. And it's a sort of synthesis, essentially, of the very, very large RACGP curriculum. What the registrars, the majority of what they'll be asked is, starting from a presentation, a patient presents with this. So it's not disease, problem focused, it's very much presentation focused. They need to be able to generate differentials. They need to be able to develop hypotheses. They need to explore these hypotheses by further history, by examination, by rational use of tests, and then they need to make a management plan, including pharmacological therapy, non-pharmacological therapy, follow-up, safety netting, managing uncertainty, all those things. Again, that's not kind of novel to you, but when you're thinking about preparing your registrar or your candidate, it's about thinking through that system. And this is really very much underpinning the case-based discussions. This is the presentation. What information do I seek? How do I put it together? And what's the management plan? And the other, I guess, facet of this is that the college is very explicit that they're going to be examining much more broadly than applied clinical knowledge, which is domain 2. Communication skills are important, domain 1, but really importantly, there'll be an explicit assessment of these other areas: population health, professional and ethical aspects, organisational and legal dimensions. And again, encouraging you as supervisors to think, how can I incorporate those non-clinical domains into my teaching? So they're the domains, touching on the curriculum. And I think the document that really underpins this new exam, and certainly, as I say, the registrars and the candidates sitting will be using as the basis for their preparation. And I'd really encourage you to have a look at, because it's manageably readable, is this clinical competency rubric. And you might think, oh my goodness, there's so many dot points, I'm getting overwhelmed here. But I think in many respects, if you look down that list, which again, I made the decision to just tease out one by one, because I think it just highlights those aspects, and I want to draw your attention to some really important resources and practical ways you can actually address some of those things. If you look at that, you think, well, that's general practice. Yeah, I can see that. There's nothing kind of there that's different to what we're doing or already covering, but it's kind of nice that the competencies, which are sort of complex tasks of practice, have been documented for you as supervisors, for the registrars, and obviously for the examiners. So my intention now is just to go through those, highlight the core elements, highlight some particular resources. What is communication? Again, you know this, basic stuff, rapport building, listening to the patient, being able to break bad news and take a sexual history and sit while a patient's crying, all those really important aspects of communication. And how do you develop skills? You role play, you role play, you role play, you role play. And just feedback on those elements of communication practice. A tip, and there'll be a tip for most of these slides, that the GPSA has a thing called a communication skills toolbox. You may find it really useful, and it's got particular relevance to IMGs. For registrars that have trained in a country where English wasn't the first language, direct your registrar there, or indeed you may tap in and see what resources you may use to help communication development. The other aspect of this first one is consultation skills, and that's very much how the consultation runs, what the structure is, how it flows. A key part of that is identifying the patient agenda. The ways of doing this is the sorts of things you've been doing, sitting in with your registrar if you've got the wherewithal to review video, but also role play. And The document that the image is of, very, very excited to highlight, is a new GPSA guide. And it's on practice-based teaching with a particular focus on teaching some consultation skills. So we're very excited to launch this. It's now on the website. If you're a registrar, read it. I really do think it would be a wonderful summary for exam prep. And if you're a supervisor wishing to support your registrar, similarly read it, talk about it, think about how you might touch on some of the skill areas with your registrar. That's the practice-based teaching guide, the second dot point under the tips. The first one is an old technique. I really do think less utilised in the Australian general practice setting than that in the UK, where it was born, and that's exploring the patient's ideas, concerns, expectations, explicit questions. I've taken your history and I've examined you and I'm not totally sure what's going on. Is there anything you're particularly worried about? Or what do you think it might be that's causing these strange headaches? Or let's agree on this management plan, but was there something else you were hoping to get out of the encounter today? So using ICE, using those key aspects of identifying the patient agenda, I think that'll be a key element in the RCE when the examiners are asking a candidate around history taking, around management planning. And lastly, you also may not be aware as GPSA members that we have put up a new suite of consultation skills teaching plans. You'd be very aware, hopefully, of the almost 100 now teaching plans on the GPSA website. The vast majority of them are clinical on topics like peripheral vascular disease or chest pain or headaches or depression or anxiety. But the new ones, of which there's I think 8 now, are on consultation skills. And I really would encourage you to have a look at these and think, yes, I'm aware my registrar struggles with time management, or, I'd really like to spend some time emphasising history taking skills. Use these in your teaching or just direct your registrar to them because they're rich with resources and tips and practical suggestions on how to develop these skills. So that's all communication and consultation skills, and we'll work our way through. Information gathering and interpretation, this is the core of it. History taking, physical examination, rational test ordering, and clearly, many good techniques, sitting in with registrars, role-playing these things, but there's a teaching plan now on all these 3 things. And what I was excited to discover was I work for GP Synergy, which is the regional training organisation that looks after New South Wales and the ACT. Well, they have a YouTube channel, which is freely accessible, and you are able to, as a non-GP Synergy registrar, supervisor, employee, click on that, and there's a whole range of physical examination videos, which again, for registrars, I think a wonderful resource, because I think this is a new, important, key area. Well, when I say new, it's always been there, but a focus on the physical examination. But similarly, test ordering and history taking. And the other thing that we've done, we just talked about all the teaching plans on the GPSA website. We've got a new document that actually highlights them, collates them, the educational resources, clinical topics, and it lists them by the top 30 presentations, the top 30 problems, the RACGP high-risk areas, and the ICPC2 chapters, so respiratory or digestive. So if you want to see what is available, that's a good way of looking instead of just scrolling through them all. So we've communicated, we've got a consultation structure, history, physical examination, and test ordering. And then there's this really critical aspect of clinical reasoning, clinical decision-making, generating a problem list. And I think there's no better place to point you and your registrar to than the Teaching Clinical Reasoning Guide, which again, I think is a really important read for registrars prior to the RCE. But again, if you're keen to try to tap into this by helping your registrar generate differentials, by exploring and interrogating and developing their reasoning, have a look at that guide. The tip there is a really interesting website, the Society for Improvement in Diagnosis in Medicine. It's the Diagnostic Error Group, basically. And they've got a little clinical reasoning toolkit for anyone who's really interested in looking. I think one of the really important take-home messages that I'd like to give you for this webinar is don't get bogged down on the new format. Don't worry too much about the 10 minutes and what exactly the questions are going to ask and how many probes and prompts that the candidates are going to get. They'll learn all that, and if you're an examiner, you'll learn all that. But for you, you're their supervisor. They just want you to discuss cases, interrogate their reasoning, help them generate a differential. And one of the really simple ways of doing that is just grab a clinical presentation like epigastric pain, put a bit of demographics around it, like a 45-year-old male who's a new patient to the practice, a little bit of clinical information, it's constant but waxing and waning in intensity, and then just a little bit of background information as you can read. And with your registrar, in our case, Andy, we can explore that case. So Andy, I thought we'd do a little bit of a case discussion here.
Okay.
You've seen the scenario. Tell me, what further history you think is important to take for Kim?
Oh, I think I want to know its relationship to food,
Yep.
whether it has any characteristics of reflux type pain,
Yep.
whether it happens at night, and whether it radiates through to the back, anything like that, whether it could be linked to, you say no medication, but I'd like to know whether you might not be taking some Nurofen or something occasionally.
Okay.
Something like that. Whether there are any other associated features, any vomiting, any regurgitation, any water brash, anything like that.
Yep.
Just check out red flags.
Yeah, very good. I'm
things
pleased
like
to that. Yep.
recent weight loss.
Yep.
And linked to that, any vomiting with blood and things like that. Any change in his appetite, whether he's still interested in food.
Yep.
Those are the main things,
Good,
Simon.
good. So tell me, I guess I won't give you that information and we don't perhaps even have it, but what sort of differential diagnosis would you entertain with this history, Andy?
Well, I'd like to, depending on the character of the pain, it could be something like gastroesophageal reflux.
Yep.
It might be erosive gastritis or esophagitis. It could be an ulcer, a gastric or duodenal ulcer. Less commonly, something like pancreatic, or less likely biliary if it's truly epigastric. And then, again, much less common, but just to bear in mind the possibility it could be something like an aortic abdominal aneurysm or something like that, but that's unlikely.
Yeah, I was going to ask any non-GI conditions you would entertain.
And I forgot to mention, Simon, that sort of obviously you want to make sure it's not a neoplasm of some sort,
Yep.
a gastric cancer or a pancreatic carcinoma.
Yeah. Any other important clinical presentations that may present with epigastric pain?
Well, occasionally cardiac ischemia can present with epigastric pain, but it would be relatively rare in a low cardiovascular risk patient like this one who's only 45 and not a smoker.
That's great. Well, thanks, Andy. I'll come back to you, but I appreciate your involvement in that case. Now, what I want to do is make a very clear distinction. I am not modelling what I would do in the RSCGP RCE, which has a very formal structure. There's certainly no, yes, that's great. There's certainly no suggesting leading candidates. So I'm not doing as I will be doing for the mock and for the real RCE. That's really important. But your role is not that in many respects. Unless you're an examiner and you're really across it and you want to practice this to the nth degree. But I think it's much better to do what I've done there, to demonstrate that, to use a case-based discussion, to interrogate reasoning, to help generate a differential, to explore, to give suggestions. Because when your registrar gets to the exam, they'll have that structure in their head and they'll be able to adapt to the formalities of the exam. Now, I'm very happy if you want to use the exam structure, but the problem is I think it is reasonably new, and I would much prefer actually this more formative approach than a much more exam structured approach. What types of questions that you may see or a candidate may see in the exam are the sorts of ones I've asked. What further history? What's your differential? What aspects of clinical examination? What test would you order? What's your initial management plan? And when you're exploring that with your registrar, you can see in blue those sorts of things. So I might have asked Andy there, how did he come up with his differential? Does he use Murtaugh's process or a model like Vindicate? What further history? He talked about red flags, maybe explore patient agenda in that way. We'll talk about clinical examination in a little bit more, but those sorts of aspects. So very much I would encourage you to do case discussion, which is not, I'm going to role play Kim with his epigastric pain, but we're going to explore the case, but with a series of questions, history taking, differential maybe, clinical examination, test, and that will give your registrar the framework, even with those prompting and those exploration questions, that will hold them in really good stead for the exam. Let's continue just whipping through the clinical competency rubric. Number 4 is basically medication management. And again, useful guide on rational prescribing. Again, I think a really great resource for registrars, and if you guys haven't read it or read it recently, have a look. This will be a core aspect of the exam around rational use of medications. Clearly accessing ETG or AMH. And the non-pharmacological therapies, there's a very good RACGP site called Handy, the Handbook of Non-Drug Interventions, if you're not aware of it. Screening and prevention, health promotion, brief intervention, motivational interviewing. Again, there are teaching plans for these topics. Have a look at them. And clearly, the go-to resource for this is the RACGP Red Book. And so my plug or my tip would be, when you're talking about cases with registrars, always think about screening, think about preventative activities, how the practice may implement them, how you may discuss those with the patient. Another really important area is on professionalism, and again, there's a teaching professionalism in general practice guide. It's really nice actually putting this webinar together, looking at these competency areas, and then looking at the GPSA resources to think, we've got a pretty broad coverage of many of these things now, which I think all these guides, which are, if you haven't read them, they're 20 or so pages, they're incredibly accessible, they're pitched at a GP supervisor, and a registrar clearly will be just wonderfully rich resources for this exam. The other really good place, I think, that you may suggest your registrar look at is the Medical Board Good Practice Guide, and also the Medical Defence Organisation resources, which have lots of good stuff on professionalism, professional practice, boundaries, those sorts of things. The RACGP would argue that that RCA is one of the most important ways to prepare your registrar for the KFP, and I would argue the same thing for this RCE by allowing you to interrogate reasoning, to pose what ifs. Again, that's not part of the structure of the exam, but such an important way of preparing your registrar for the exam. That is the quintessential way of exploring and identifying registrar unknown unknowns. Our very accommodating registrar, Andy, is back. And Andy, I see we've just pulled up this chart on Angelo from, I think you saw him yesterday.
Yeah.
Look, ordinarily I'd get you to present the case, but we're running a bit short on time here. I'm just curious to know, can you just take me through, just describe to me how you examined this man? What did you actually do?
Well, I initially got him to lie down on the couch,
Yep.
and because he's got this persistent inguinal hernia post-repair pain.
Yeah, sorry.
So I inspected his abdomen, I properly exposed the genitalia and the inguinal region,
Yep.
and then I gently got him to do some coughing, just to see if there might be some kind of cough impulse. And then I palpated his inguinal canal very, very carefully and
Yep.
tried to elicit exactly where he's getting this pain.
Yep.
And it is right over the scar. There's a bit of thickening of the scar. And then I also got him to stand up because sometimes I think you can elicit a weakness in the abdominal wall if they're standing, and then they do a cough impulse as well. So that's mostly what I did, Simon.
Okay. Now, thank you very much. So this man, what if this man presented to you, his ultrasound's normal, but he presents to you and he says, Andy, what I'd like is a medical certificate, please, for when I saw you back then for a couple of days. Yeah, I just keen to get a couple of days off, please. How would you approach that situation?
I'd try and clarify exactly why, because this is quite a long-standing problem. So,
he says he's got a bunch of sick leave and he actually had to go down to Sydney to sort something, but, the boss would be fine about it.
I'd struggle with that because I don't think that would be professional of me unless it was a genuine reason for him to have a certificate. I think my colleagues looking at that would not think that was appropriate behavior by a professional doctor. And so I'd need to query that. And I think ultimately I wouldn't be prepared to issue such a certificate.
Okay, so how would you decline that certificate?
I'd explain that, in a sense, if he was seen walking around on holiday down in visiting relatives and his employers became aware of that, essentially, as a professional person, I'd need to be able to hold my head up high and justify that that was a medically appropriate reason for him to be off work. And when you sign a certificate and put your signature to it, a lot of society expects that to be for a valid reason and for you to be able to justify it. And in this situation, I feel that I've erred badly.
So again, thanks, Andy. And so the value of random case analysis for those who are doing it, as you'd be aware, is that you can explore the what ifs. You can take the scenario well beyond the actual clinical case. In this case, professionalism. So I'd encourage you to explore the domains beyond the clinical. But the other point I was wishing to demonstrate here is that where there's an opportunity, through whatever mechanism, you've observed a registrar in practice, you're at the end of the day having a discussion about a problem patient, you are doing an RCA or you're doing a formal CBD, encourage your registrar to talk through the physical examination as you just observed Andy do. And obviously haven't got time, but in terms of giving feedback, pointing him to the appropriate resources, because that is going to be a key element of the new RCE. And again, there's no RCA in this exam. And the questions I've asked Andy are not representative of what the formal structure of the RCE is, but you can see the registrar getting supported in this way is going to be able to go into the exam and adapt to the formality of the structure of the exam quite comfortably if they've had this level of clinical reasoning interrogation as you prepare them. We're almost there. Clinical practice systems and requirements. So this is all the kind of organisational stuff, recalls and computers and medical legal stuff. I really do think the MDO resources, if you're not using them or suggesting your registrar look at them, there's some fantastic simple resources through, I'm with Avant, but I know MDA are another big organisation and I think support GPSA. So have a look, and they're all readily available actually. You can see each other's resources. Procedural skills, but this again is going to be a really important highlight of the new RCE, that you're able to describe a procedural skill. The rubric would talk about being able to demonstrate them and refer appropriately. Clearly, as your registrar in practice is seeing and doing procedures, supporting them to be able to be competent in those things and knowing when to refer. But you may wish to tap into something like Murtaugh's practice tips. RTOs will have their own resources on procedural skills, and really just directing them and ensuring, talking about this explicitly. You will be asked about this stuff. I know our practice doesn't cover this. We don't do many procedures here, but it's really important you know how to do these things. How can we support you to do that? Managing uncertainty, it's a 2-hour lecture in itself, but basically how your registrar can deal with the undifferentiated presentation. And again, there's a guide for that. And lastly, I think this is Cavendish coming off his bike in a bunch sprint. That really is the moment before a world of pain and possibly a fractured clavicle and a loss of a lot of skin. So the critically ill, the significantly ill patient, and sort of awareness of limitations. And again, this is interesting because this isn't something we see a lot of in general practice. We don't tend to see lots of really unwell patients. And we have a bit of a sense of our registrar's competence in that. And again, that may be something that may be not a strength of yours, but pointing them to appropriate resources, resuscitation guidelines, the RTOs, the host training organisations will have a lot of information, I imagine, but online resources like RACGP, GP Learning. So I've just stepped my way through the 10 items of the rubric. And I did that deliberately because I wanted you to get a sense that those things are relatively common general practice aspects, breaking them down into their core elements, they're kind of pretty achievable in terms of the sorts of skills the registrar may wish to develop, and also highlight some of the tips and resources that you could use. So we've seen this slide before. Understand what's being assessed, know these documents, keep going with your practice-based teaching, case-based discussion, RCA, problem case discussion, just the usual stuff. But think they've got their RCE coming, focus on physical examination, focus on procedures, just step my way through those core elements of the case, interrogate reasoning, support reasoning, those sorts of aspects, clearly direct them to the appropriate resources. There are, and the registrar will know, the RACGP exam prep resources, we've already talked about those, and the RACGP GP learning exam support modules. Really importantly, encourage your registrar to learn from their clinical exposure. To basically, hopefully they're doing that, but just even the most banal of sore throats, which isn't anymore because it could be COVID, I'll have to get a new example, but to say, what's the differential? Could I be missing here? How do I manage this? How would it be if I was asked this in the RCE? And I must say, I've got somebody to thank for flagging what was a real oversight, and that is basically provision of pastoral care to your registrar. We've just had the Are You OK Day last week, and I've flagged at the outset that this exam has caused significant stress to a lot of candidates and registrars indeed, and you're probably looking after these guys. And so getting a sense of how they're going in amongst the rest of their lives, their family and personal lives in this otherwise very difficult time anyway, to have to grapple with the new exam. So really important aspect of what you can do, I think, is support your registrar's mental health and stress levels and connecting and making sure that they're going okay. Really, the most important thing you guys can do is to focus on skills. The registrar, and this is from the day they start in your practice, clearly it's nice for them where you can walk in and say, that's pityriasis rosea, that's because of this. And they want that, and that'll happen. But the more we can focus on skill development from the outset, the more in the future that's going to translate into, I think, better success in exams like the RCE. These are my top tips to take away. Teach to your strengths. And I think, I may be getting in trouble for saying this, but I don't think I will. If you're complete rubbish at critical appraisal of research papers, fine. I don't think, and I wouldn't expect you to go off and upskill in that. That's the registrar's responsibility to find somebody who can help them with that, and it's going to be somebody at the RTO or lots of other people. But your skills might be in a whole, range of clinical or non-clinical areas. So teach to your strengths and enjoy your teaching. Be enthusiastic about it. Focus on physical examination, we've talked about. Consider the non-clinical stuff we've talked about, professionalism, legal stuff, organisational stuff. And I would say, I really would encourage you not to get bogged down with the new format. That'll work itself out. The registrars will know how to do it. The examiners will keep them right. You should be teaching the skills. So don't worry too much. I think about the 10 minutes and the reading time and the 3 minutes for this aspect of the question. It's about you actually using case-based discussion, using RCA, those sorts of things to teach the skills we've talked about. One of the really nice tips is getting a registrar to document their reasoning in their notes. So, Andy might have put in for Kim Wu, if there'd have been a patient he'd seen, epigastric pain, query ulcer, query GORD, query ischemic heart disease, but seems unlikely because X, Y, and Z. That is a really powerful way of teaching reasoning. Get your registrar to read this rubric and self-rate and go, you know what, I don't know, I haven't got many weeks left, but these are the areas I think I'm completely struggling with. How can we support this in the little bit of time left? But obviously we're talking about future RCEs and, doing that with a bit more time. Using the resources that are available to you, and possibly most importantly, manage your registrar's anxiety and stress. And I put don't forget travel medicine because I was reading in preparation for this exam and was very interested to see that it said the registrars can still be asked about travel medicine even with what's happening with COVID. So that was an interesting point. I thought I'd just add it for fun.